I want to welcome everyone to tonight's webinar, Promoting Self-Management with Self-Catheterization, brought to you by the Illinois Spina Bifida Association and sponsored by Hollister. My name is Rachel Gallant, and I am ISBA's Clinical Program Designer and an occupational therapist by background. I will be tonight's speaker, and we will have ISBA staff facilitating the webinar. Before we begin, I just want to go over some housekeeping notes. We are recording tonight's presentation to be viewed on demand, and we'll be sending the link to view to all who have registered. We'll also make the recording available on our website and YouTube channel. We encourage questions throughout the presentation by putting your questions in the Q&A box as they come up. If you would like to remain anonymous with your question, please check the anonymous box before posting it. We will try to answer these in real time and verbally, so they are captured in the recording. If there are any questions we do not get to, we will send answers out via email, as we want to make sure everyone's voices are heard. Attendees can use the chat for any technical issues you may be having, and we may be sending notices out during the presentation through chat, so just keep an eye. After my talk, we will have a brief presentation by Tara Diaz from Hollister, our generous sponsor tonight. Thank you all again for attending tonight's presentation. We really appreciate your participation and attention to this important topic. Finally, a survey should appear in your browser when the webinar is ended, and please complete that, as your feedback is really important to us for future programs. So, I'm just advancing my slide. There we go. All right, so at the end of tonight's talk, I want you to be able to describe typical norms for independence with activities of daily living for children with spina bifida. Also describe challenges to independence for children with spina bifida, and demonstrate understanding of teaching activities of daily living skills with strategies, adaptive techniques, and/or equipment. And finally, demonstrate understanding of self-catheterization training and specific challenges to children with spina bifida. So I've done this talk over the years. I used to work at Shriners Hospital for Children in Chicago and was an OT there. And I always had the title of this talk include the word independence. But I recently attended a Spina Bifida Association national webinar called Raising Independent Children with Spina Bifida. And the question was, are we really shooting for independence? So before we begin, I want to think about these questions. So are we shooting for independence or more interdependence? And interdependence is dependence of two or more people on or things on each other. And we could be talking about self-direction, which is the ability to make your own decisions and organize yourself rather than being told what to do. Or self-determination, which is a person's ability to make choices and manage their own life. And finally, autonomy, which is independence or freedom as of the will or one's actions. But then the title of my talk includes self-management. So that's where I landed. Berkeley Wellbeing Institute defines self-management in simple terms as our capability to better manage our thoughts, regulate our emotions, and hold ourselves accountable for our behaviors. And according to SBA guidelines, self-management for youth and emerging adults with spina bifida is an active, daily, and flexible process in which youth and their parents bear responsibility and decision-making for managing their condition, health, and well-being through a wide range of knowledge, attitudes, activities, and skills. And that's why after all these years, I am kind of switching to that self-management piece, because not everyone achieves full independence, but we do hope you achieve self-management. So activities of daily living. Souza, back in 1983, studied children with spina bifida and how they differentiated between the initial skill completion and the routine task accomplishment, which can really vary greatly. So you might achieve a task, but you might not consistently do it. Factors that affected obtaining those skills were perceptual motor impairment, upper extremity incoordination, spinal differences, lower extremity contractures, to name a few, and then another slew of other factors that are listed below. SUSE also looks specifically at these activities of daily living components. So things like taking clothes off, which is usually acquired before putting clothes on. When you look at typically developing kids, which is in the TD column, things like removing socks and pants are usually acquired around a year and a half or 2.5 years old. And then you can compare it to the other columns based on motor level of spina bifida. And you can see the various changes in those ages that those skills are acquired. And the same goes for dressing. Removing braces is specific to kids with spina bifida, so we can't compare them to typically developing kids, but there's still a range based on the motor level. And then we also look at activities of daily living, such as eating, grooming. Grooming are things like brushing teeth, washing hands and face, things like that. And there's a range of ages that those are acquired. Sometimes it's not that much different. Things like eating, there's not a big variation, but there are for other skills like cutting with a knife. And then we also look at some personal and social milestones, things like doing chores around the house or playing simple games, crossing the street without supervision. There's also a wide range of acquisition here based on motor level in spina bifida. So later on, in 2006, there was a study that Davis did on the age of acquisition of skills for adolescents. And in this study, it showed that adolescents ages 12 to 18 years old are delayed 25 to 30% in autonomy skills and acquire these skills 2 to 5 years later than typically developing adolescents. So this just kind of gives us a lens into what we can expect. Because when I used to work in the clinics and Shriners, I think parents were really wondering, when can I expect my child to do this? And this really helps to kind of gauge that. It's different for everybody, but it really helps. And then some other more updated guidelines through the Spina Bifida Association national website. They have a great guideline on self-management and independence, and this really gives a roadmap to expectations for skill development by age. So this really gives an even closer view of when to expect these things and when to start trying to practice. And then more specifically, the National Spina Bifida Association also has a urologic care and management guide, which can also help us to determine what age are we expecting our kids to acquire this specific skill, which again is not a skill that typically developing children have to acquire. So we really have a need for ADL performance evaluation and monitoring in children with spina bifida. Things like physical limitations, learning difficulty, and frequent overdependence on adults might interfere with performance of ADLs. Sometimes when I worked in the clinic, even bringing up the idea of getting your children involved in these skills were sometimes foreign. Parents weren't thinking that they should involve their kids because they just assumed that they should be helping with all these skills. And it was sort of like an aha moment or a breath of fresh air to think, you know what, I definitely should be involving my kids in these tasks. And key areas to assess for self-catheterization, I always said that self-catheterization is sort of the graduation ADL, because if you're not helping with dressing yourself, bathing yourself, feeding yourself, using the bathroom, or getting onto the toilet or the tub, it's really hard to jump to self-catheterization. So we have to look at these other skills first. And OT really plays an important role in assessing these readiness skills, even decide if a child is ready to learn. Again, things like self-care and what is their participation in their catheterization program already? Are they helping get supplies out? Are they helping wash their hands? Are they not doing any parts of it? That's really helpful to know. Also, knowing about general mobility, how they use their hands, and cognitive and visual perceptual skills are all areas of focus that an OT can really be able to determine. And finally, in a life satisfaction study for young adults with spina bifida, it was found that most with spina bifida were unhappy with their level of self-care skills than people in the general population. So that just goes to show it really helps with quality of life to be participating, whether it's being independent or having a role in that self-management. So treatment ideas to promote early independence with ADL. There's so many ideas. It can be overwhelming. A lot of times, like I said, sometimes I, as the OT, was the first to suggest that their child could participate in these things. So first, thinking about using adaptive equipment, adaptive methods, or sometimes adaptive clothing, if it helps to open, have a quicker opening to the pants with a Velcro underneath instead of regular sweatpants or regular pants that you have to pull all the way down. We also make recommendations for safety with bathroom transfers that could include using a bath chair, reachers, dressing aids, grab bars, having just more safe environment in the bathroom where, people can be prone to falls, it can be slippery. Also find motor activities to improve hand function and involve your child in the steps. So hand function is so important. Think about holding the catheter and having a sustained grasp or pinch of that. Also even opening the catheter package. And then also involving your child in every step of the way, what they can be involved in. Also, we want to look at increasing functional mobility. So how do they do with those bathroom transfers? And also positioning can be key with self-catheterizing. It's not a one size fits all. Some kids are on the toilet, some kids are in bed, some kids are in their wheelchairs. And it's not going to be the same for everyone. Also use of visual cues, things like stopwatches, sticker charts, reminder signs of the steps, maybe posted on the wall, or cell phone reminders. There's so many apps now that help to organize to-do lists that you can also set alarms. There's so many options. And then backward and forward chaining, which is if I start the activity and my child will finish it, or if my child starts the activity and I will finish it. So it's sort of like helping along the way, but not doing all of it. And then finally, using bedtime and weekends to practice. I am a parent, and I know that getting ready for school is not necessarily the time to be focusing on these tasks, which take a lot of time and effort and can be stressful. So I've always recommended using bedtime when you have a little bit more time, or the weekends to practice, since time constraints can be so frustrating when you don't have that time to study. So collaboration with families. We want parents and family members to really be assured that it's normal for your child with spina bifida to acquire these skills later than typically developing children. What we've been talking about since the beginning of the talk. And also be reassured to know that your specific child can be assessed based on multiple factors to determine when to expect certain skills to develop. Every child is different. Every person is different. We need to individualize that. We also have to think about home modifications and or adaptations, along with suggestions for a therapy program that can be implemented to implement these skills, as well as how to deal with frustration, because it can be so frustrating to the point of maybe not wanting to do this anymore. So how do we not push it so far to kind of push us to the edge when we're so frustrated? And finally, parent cooperation. In the clinic that I worked in, I had several parents who would go to school to catheterize their child. It would be convenient sometimes not convenient. And you really have to be on board if it's not something that your family wants to wants to work on, it's not a priority, then that's really important. But if you are interested, you really have to be on board, and accept and learn or cooperation in accepting, learning, and teaching, so that your child can be successful. And we also want to set expectations that build on self-reliance. So, keeping expectations realistic. It's often easier to say, it'll be faster if I do it, which is the same for any parent. And why is self-correction so hard to develop? There's so many things that you have to think about beyond cathing. You might be managing braces. You might be thinking about monitoring your headaches or a shunt malfunction. You have to think about press release and skin integrity. There's so many things to keep track of. This is just one of them. Also, executive functioning deficits, including things like initiation, organization, and working memory, are factors. So it can help to break things into steps, like the chaining that I mentioned before. Have them start a timer, have them help with setup, anything like that, to help them be involved. And then thinking about equipment and adaptive techniques. So these are not related to cathing, but like I said, in order to have that success in cathing, it's really helpful for you to master some of these other ADL skills first. These pieces of adaptive equipment on the screen are different things that can help with dressing. A sock aid can help you get your sock on if you have a hard time reaching or with positioning. A foot funnel or a long-handled shoe horn can help you slide your foot into a shoe, especially if you're wearing braces. It's so easy to just smash down on the back of the shoe. Some of these things can help to prevent that, to keep the integrity of the shoe with braces. And also things like elastic laces. If shoe tying is not a priority, what kind of other fasteners for shoes or slip-on shoes? What's going to work for you? I used to use this dressing chart as a way for a motivator. So not all kids like sticker charts, but some are motivated by them for sure. And if there's a reward at the end, that can even be extra motivating. So this is like a sticker chart. And you mark or put a sticker on the box where they participated in helping to either take their clothes off, put them on. It doesn't have to be complete independence to get the sticker or to get the happy face in the square. Just did they participate? It doesn't have to be full independence. And sometimes you can make it into a game with the stopwatch to see how you can beat your score with how fast you can take off your clothes or get dressed in the morning. And then some ideas for helping with dressing can be to set clothes out the night before, making sure you have enough time, like we talked about, practicing at night and on the weekends. Also, the surface is really important. Sometimes people try from bed and it's too squishy, and you kind of sink into the bed and it's really hard to get into a good position. So sometimes even on the floor or a corner where you can even be more supported, or just a stable surface. And also the adaptive equipment that I showed, if it just gets in the way, definitely forget about it. You don't want to use adaptive equipment if it just is a distraction. Also, for putting pants on, if you're unable to stand, an idea is to roll side to side on your back to pull them up all the way. And if you can't pull them up all the way, even rolling onto your belly to pull the pants up all the way over the bottom. Things like putting socks on, you can position in long sitting, which just means having your legs straight out in front of you, and reach to your feet, or cross your legs to access your feet better if body position allows. And you could consider pull-ups instead of diapers for leaks, since they're more like underwear. And now, in today's day and age, there's a lot of different technology with underwear. There's leak-proof underwear that's often used on the market for periods, but can sometimes, be sort of an extra layer of leak protection. And then some specific adaptive equipment for toileting. If your child has a hard time reaching their bottom or their back perineal area after a bowel movement, these tools can help if they have a hard time reaching. So one is called the Bottom Buddy, but they're all a different kind of toilet aid, is what we call them. And then these are adaptive equipment pieces for self-catheterization and skin inspection. The one on the top left is a handheld skin inspection mirror. You hold in one hand and you position your body, and it's a flexible neck so that you can even put it in, to have it really hone in on certain spots. If you're looking at your bottom or the bottom of your feet or what have you. Top right is a knee spreader where there's a mirror that's Velcro to that bar, and this can really help girls to position legs in abduction or stretch them out to the side, and having that mirror as a perfect placement for being able to see what you're doing. And then the bottom mirror is really just a mirror that you can get at Walgreens or any store that can just sit on a surface, whether it's a hard surface or the bed or what have you. And then the catheter technology has really continued to develop since I've been specifically out in the field. But straight catheter is kind of the basic catheter, but then there's also closed systems where the catheter is in the bag, and the catheter is advanced without even having to touch it with your fingers. There's also compact and pocket travel catheters that are super discreet, and they've also been produced to make it easy to open if anybody does have a fine motor deficit. And then there's hydrophilic catheters, and finally just a procedure, the Mitrofanoff appendicovesicostomy, a procedure which changes the where you are cathing through a stoma in your abdomen, and that can also help greatly with independence with cathing. And then looking at durable medical equipment for toileting. These are different types of commodes. So the first one is a standard bedside commode that can be used just by itself, or it can be put over the toilet to sort of add to the stability. It kind of gets grab bars. And a drop arm commode, this one is padded, can ease lateral transfer. So if you have a hard time transferring to the front of that regular bedside commode with fixed arms, this one has arms that lower down and really kind of give you more surface area to be able to transfer. And that final one is a pediatric size commode that is much shorter than a standard commode. And I used to have some kids that would be able to crawl over to the pediatric size commode and lift themselves onto that. And it's a lot different from like a standard potty seat, which doesn't have all those supports. And then more specifically, some items that we recommend to put on the toilet. The Cushy Tushy is one that I learned from my clients back at Shriners, which is just a standard ring reducer, but it's cushioned. And it might not last forever. It might lose some cushion, but they're fairly cheap and, off the counter. And then there are some things that are more medical equipment, like the padded toilet ring reducer, which is really fitted well for the standard toilet and gives more of that gel cushion. And then at the bottom, you'll see different RoHo products, which is that open air cell that you have to make sure is filled adequately, not overfilled, not underfilled. But these are probably the best products for if you have skin integrity issues, if you have lack of sensation, especially for long time sitting on the toilet, because you can get a sore from sitting on the toilet for an hour if you have a bowel program that takes an hour. And the one on the left is one that forms to the toilet seat, and the other one fits better onto a regular commode, and it's just one piece. And then also some popular things along the same lines that go over a toilet are the Prince Lionheart WePod or the WePod, the WePod Basics. These are really popular with kids with spina bifida, and also nurses have recommended in other talks that I've been to as well as Colleen Payne, who's a great parent advocate and created the Parent's Guide to Cone Enemas, which this was originally from. And then for larger children who outgrow toddler potty seats, a popular option is the special tomato ring reducer. And it can be purchased in elongated or round shape, depending on the shape of your toilet. It gets a little bit more expensive when it is like from a medical supply. So you have to just kind of see what works for you and what's going to be best for your child. And then another basic over the potty seat is a Graco Clean Contour Potty Ring. I learned about this one recently, that it's also really good for kids with spina bifida and stable over the toilet. And then finally, for kids who need a little bit more trunk support or help balancing on the toilet, the Rifton toileting system is really good. Also, like I mentioned, this was originally from Colleen Payne, who wrote a guide to parents for cone enemas. She also liked it because you can get your hand underneath the seat a little bit easier for that. And besides a proper seat, you might want to get a stool so that your kids' feet are not just dangling, especially if they lose circulation, especially which is true with spina bifida. So things to think about. All right, self-catheterization, training and challenges. So we have some challenges ahead, but things are possible. So some of the barriers that we look at, we kind of touched on some, but specifically, is the whole family on board? Is the child on board, and are the parents? It has to be kind of a team effort. And is the child motivated? Is the family motivated? Do they want to go to a sleepover? How are they going to be able to do that if they can't bring their parents? What are some things that motivate them? Also, we've talked a little bit about cognition and safety factors, deficits with executive functioning, and really being able to do the sequencing, get all the steps, make sure that you're washing your hands and being safe. And like we've already talked about, there's so many things to keep track of. This is just one more thing. And some kids have challenges with positioning, maybe with mobility. Also, one piece that we haven't talked about yet is anatomy and body composition. Sometimes it is really hard, even for a healthcare professional, to catheterize someone. And that happened in my experience, whether it was through clinic or on the inpatient unit. Sometimes it was really, really challenging, even for healthcare providers. We all have different anatomy and different body composition that affects being able to do this more easily or not. Especially for girls, it's important to sort of have an anatomy lesson, because it's so different for boys that have external anatomy. Girls have to understand which hole is the right one, and that there are multiple holes. Being comfortable with your body and really sort of getting to know your body a little bit better. Also, a barrier could be if you're prone to UTIs. A parent might not want their children to be involved because that might increase the risk for getting UTIs. So some parenting struggles are that you want to be protective of your child, but you want to give them opportunities. Also, we've talked about wanting to get things done quickly and, getting out the door versus promoting independence or that self-management. And you also, as a parent, want to advocate for your child, but you also want to sort of pass that baton to be able to have them self-advocate for themselves. You also want to be protective again, but you want to trust your child. You want to trust that they can do it. You also want to trust, they might make mistakes and that's okay. And you also want to learn to be comfortable with ambiguity because it's not all clear. So the next few slides just show an assessment that when I was at Shriners, we put together and updated an old evaluation with a COTA student we actually had who sort of updated our assessment. And there is no official assessment or objective outcome still out there today. But based on the areas that we need to assess, this evaluation was created. So just to give you an idea of what kinds of things we would be looking at as an OT a little bit more clearly, and some of these, we've touched on a lot of these things, but this kind of gives you a better view of what our assessment looks like. So we're interested in what their current catheterization program is, their general hygiene, and what their participation is now. We want to know how independent are they with their ADL skills now? Are they participating in them? And this is just a scale of how much help they need, whether it's mod-I or independent in the first column, all the way to D, which is dependent, and everywhere in between, whether it's min-assist, mod-assist, max-assist. Then we're going to look at their sitting balance, which is important. Do they need help for different positions? Also, we're going to look at, are they ambulatory? What do they use for mobility? Like I said, sometimes people are catheterizing from their wheelchair. If they have a wheelchair, if they're not, then we're going to look at, can they do it from the toilet or another surface? And then we also want to see how they're transferring. Do they transfer with help or independently? And can they do a bed transfer? Can they do a toilet transfer? Things of that nature. And then we want to see if they can do all these sitting positions. So short sitting is with your feet, with your legs over the edge of a regular chair. Long sitting is with your legs straight out in front of you. Ring sitting is bringing your legs together with your feet kind of touching in a ring. And are you able to weight shift and shift your body into different positions? And for girls, do they have adequate hip abduction, which means they can spread their legs enough? Then we look at specific hand skills. So we measure grip strength, and we measure their pinch. So lateral pinch is like a key pinch. And we might look at different types of pinch, sometimes hip pinch, sometimes it's 3 jaw tucks, depending on how they're going to hold that catheter. Also, finger abduction. Are they able to spread their labia with holding their fingers abducted for a longer period of time? Also, we want to see what their grasp patterns are like for different things like a pellet, a block, and an actual catheter or a string. And then in the lower right, you can see what the kit that we put together was. It was specific to casting. It had flashcards in it. It had all of the fine motor tools to sort of assess these things. And also opening packages are also one in there. And then finally, we're going to look at in-hand manipulation. Can they get items from their palm to their fingers and back? Diagnosis is, can you tell what is in your hand without looking? Do you need that visual cue, or can you tell what's in your hand without looking? One activity I used to do with kids is bringing beads in a pillowcase. So they weren't able to look at what's in the pillowcase, but could they do it just by feel? Because even if we're using things like mirrors, we would love for them to be able to tell these things by touch, eventually not always have to use a mirror. And finally, just visual perceptual skills and different cognitive skills that we all are also looking at. The sequence activity was flashcards for making a sandwich. So, we're not necessarily quizzing them on what are the steps of cathing right away, but can you sequence these flashcards in order for being able to put a sandwich together and all the preparation that goes into that and getting to the finished product. So we've already talked about these things, but it's just a reminder now that we've sort of gone through all the things that we're looking at and what can help, whether it's adaptive equipment, fine motor activities, working on those transfers, thinking about visual cues, and also specifically using a good time in your family to work on these things. And then teaching tools that we've used in the past. The first one, flashcards with steps. You can have some companies have their own flashcards, or you can make your own, starting with setup of all the items, making sure you wash your hands, making sure you have adequate setup, and being able to open the catheter package, being able to target the spot that you're going to put the catheter in. Can you put the catheter in? Can you insert it? Or can you remove it? So we want to make sure that they can sequence these things in the correct order. I also mentioned before that there's so many apps now that remind us to do things. So whatever works for you, whether it's on a watch, there's kids watches now that are sort of kids smartwatches that don't have to be a regular smartwatch, but tailored to kids that have their own timers that have tasks that they need to do, and you can specifically add cathing into one of their tasks. Cathing dolls are great to normalize, what we're doing. Hollister specifically has, this is a picture of a shadow buddy. They have their own dolls that you can, use to practice on and sort of normalize. There's also videos, so many teaching tools online. Each catheter company really has their own teaching tools, some nice videos of beginning to end of the step-by-step process. And there's different ones for boys, for girls, going through anatomy review and making sure that you know where everything is, you know where your landmarks are. The hand sanitizer with wash activity is an old one that's sort of like a blue light concept where you put this special cream on, and then you use the blue light to see if you got it all off by washing your hands. So that was kind of a neat thing we used to have. And then reading books and coloring books on the topic. There's a lot out there that just regular children's books about catheterizing from some of the cathing companies. And then also talk to each other, see what works. I have learned so much from patients and families and my clients through the years that I've been able to share with others. So that's really key, is networking amongst yourselves as well. And then figuring out what is going to be the best surface. And can you do multiple surfaces? What if you're at school? What if you're at a friend's house? What if you're at home? So does it always have to be a bed? Does it always have to be the floor? Kind of figure out, multiple options, or what the best option is going to be. And then HEP stands for Home Exercise Program, and that's for a variety of the related skills. So any of the skills that we've reviewed can be prescribed with the home exercise program to work on those specific skills. Some other challenges that we might come up against are, like we've talked about, female anatomy is much more difficult to navigate. Sometimes sequencing the steps, you might forget one of them. You might forget a crucial one, and looking at those executive functioning deficits. It's really hard when a child is not involved prior. So if you're just introducing all of this, right up front at, 10 years old, it's hard if they have not, if they haven't been involved up until this point. Also, sometimes, and I had this, I think as an OT, I had to sit on my hands as well. Sometimes family members might jump in too much, and not following through on having the child do more, or the parent might take the lead and just say, okay, I'm just going to do it, instead of sort of waiting it out. And sometimes you will have to, but making sure to sort of like sit on your hands and not jump in too much. And there's really more success when a family follows through with the practice, seeing what works and what doesn't. Just like an exercise routine. You know, if you say today is the day when I'm going to start exercising, you do it today, but not tomorrow or the next day or the next day. You got to stick with it for it to have any long-term effects. And the best case is when the family coaches. You know, the family can help uh, give their like what has worked for them in pathing their child. That could help your child, but not to actually have hands-on participation. And then encourage more independent problem solving instead of giving all the answers, because maybe your child will figure out a different or new way that the parent or family member hasn't thought about. And then I just wanted to touch on this. When I was at Shriners Hospital, I did a study, a retrospective study, to look at effectiveness of inpatient hospital stays for self-cath teaching and independence. So we, long time ago, we were able to have our kids come and stay for a few days in the hospital and sort of have sort of more of a boot camp level of practice, and having the nurses and the OT sort of team teach for a period of time and really, really focus on this task accomplishment. So it was a small group, but the ages were on average about 11. We had 3 males and 10 females. And like I said, we identified kids in clinic that were good candidates. And these are all the things we did. The OT in interventions used flashcards, the teaching doll, all the things I've already recommended to you, as well as readiness activity skills like specific fine motor strengthening, working on dexterity, all of those activities that we need that complement this skill. We also collected data before the training, at discharge from the hospital, and when they came back to clinic. And for the most part, kids, about half used a mirror, jumping down to aids to catheterization. And some performed it in bed without aids, some used a toilet, and some used a toilet with a mirror or without. And we're also looking here at prior to training, half the participants were completely dependent for catheterization when they first came in, and about a third were dependent with just the catheter insertion, but they helped with other tasks. And by the time they got discharged, a third required assistance with the insertion and cues for pre-cath, and 62% were independent except for verbal cues. And when they came back to clinic about 6+ months later, 1 participant required assist with the catheter insertion. 23% were independent with the catheter insertion, maybe just needed a little bit of cueing, and 62% were totally independent. So this is just to say that this unique model of intensive inpatient hospital stay and OT intervention, most participants with spina bifida really made great progress and maintained it or surpassed it at the follow-up, which was really exciting. So this was just a really small retrospective study that I did. A colleague of mine, Morgan Kane, out in Vanderbilt, also an OT, did more of a systematic review in the last few years to see what the literature says and if there's any standardized assessments, treatment, recommendations for teaching, and also what are good indicators for having the urological surgery. And basically the conclusion is really that there's nothing standardized, but that OT can help. And specifically, she recommends the co-op model, which is cognitive orientation to daily performance. It really helps to improve patient performance in self-identified motor-based goals and emphasizes facilitation of a global cognitive problem-solving method. So you have your goal, you plan, you do it, and then you check. So the take-home messages that I want you to leave with today are that kids with spina bifida can be independent with their activities of daily living. It might just take longer than typical children, and that's okay. We really want to support families with encouragement, any kind of adaptive techniques or equipment and strategies that may help. And self-catheterization independence or self-management is challenging. And it's really only realistic if the child has mastered other basic self-care skills before jumping into self-catheterization. And finally, just consider OT if you need help. Sometimes setting up an outpatient stint of occupational therapy to address the skills that you're seeing or you're not sure, why it is so hard. And OT has a really keen eye to address some of these skills, a lot of these skills that are needed for self-capping. So with that, I want to thank you guys for listening to my talk. And now I'm going to turn it over to Tara to tell you a little bit about Hollister. And we thank them so much for their sponsorship of this event and partnership.
Thank you, Rachel, and thank you for allowing us to participate in tonight's event. It's always great to connect with end users. So Hollister is a global healthcare company. Just wanting to go through some of the products and that we currently carry for this particular group. So I just wanted to go really quickly about the product portfolio and the navigator support service that we have. So Hollister is an independent and employee-owned company, and we've been serving customers for more than 100 years. Currently, this is our continence care portfolio. So we do have our only intermittent catheter. So that is our hydrophilic catheter. And we also have the Infina Chic, which is specifically for female or even children. So these are both hydrophilic catheters. What that means is they're pre-lubricated out of the package. So there's no need for lubrication or gel. They're ready to use as soon as they come out of the package. This is currently our vapor line. So the vapor line is also another pre-lubricated catheter that we have. What's great about it is 100% touch-free. As Rachel mentioned in her presentation, unfortunately, UTIs is a reality that a lot of children and adults will also have to face through their lifetime as long as they're catheterizing. And so what's nice about the Vapro catheter, it is 100% touch-free because it's completely enclosed in a protective sleeve. And it also has a protective tip, which allows for the 15 millimeters of the distal urethra to be protected, where we know a lot of the bacteria is introduced into the bladder. You'll also see that, as Rachel mentioned, we do have one that is compact. And so if you're traveling, it will allow for you to travel with it. So as I mentioned, it has a protective tip, it has a protective cap, and it has a protective sleeve, which again, that no touch protection, that is great, especially when you're catheterizing, 5 to 6 times a day. It helps protect from, any potential bacteria. Again, just highlighting the fact that the protective tip is actually reduces E. coli, which we know is a kind of one of the bacteria and the bugs that are responsible for UTIs. So yeah, we can probably skip the slide. It's just saying that it passed the ASTM. Navigator is our support service, which is great because for children and for teenagers who do require catheter support and services, the Navigator brochure is it's a support service for ABC Medical. Next slide. So we do partner and we provide a lot of educational information and resources, and it really connects the end user with the retailer to be able to purchase their products. But more importantly, it also provides a lot of resources like education and where to purchase your intermittent catheter. And if you're having issues, especially for teens and children with spina bifida, for parents, there is a lot of support with the navigator. And so this is a service that ABC Medical provides, which is a company that is affiliated with Hollister. And that's it. Thank you so much for giving us some time. And if you have any questions, please put it in the chat. Thank you.
Thank you so much, Tara.